Attending the course. I'd like to thank deeply Professor Dr. Samir and Dr. Maha because they made my life easier. Retinal vasculitis is a descriptive term. As we all know, it's not a disease identity. We should find prevascular sheathing or cuffing, vascular leakage, and or occlusion. The causes, as Professor Samir mentioned, tons of causes. Any form of uveitis can be associated with retinal vasculitis, bacteria, if we consider infectious, bacterial, viral, parasitic, rickettsial, neurological disorders, malignancy, systemic inflammatory diseases, and ocular disorders. We have many causes that make our life difficult. Also, when we are going to order investigation, we have list of investigations that no one can do. What makes our life easier, as Professor Dr. Samir mentioned, there are clinical milestones of vasculitis that we should answer the questions about it. Question 1, vessel affected mainly, whether arterial, venous, or combined. Question number 2, what is the nature of vasculitis? Is it occlusive or non-occlusive? Question number 3, size of the vessel affected. Is it branch or main trunk or peripheral one? Question number 4, the segmental affection, is it present or not? Then we should answer the systemic milestones of the disease. These are very important in the diagnosis. We should ask a full history from the patient as recurrent oral genital ulcer, recurrent abortions, recent urethral catheters, physical signs as nail biting, skin signs as acneiform rash or mala rash, etc. We should take a detailed history from the patient. Application. Let's start with our cases. Case 1, a 30-year-old healthy female complaining of left diminution and blurring of vision. There was no past history of systemic disease. As we can see, there is a vascular sheathing affecting mainly the lower veins, as we see here. But as we look up in the fundus, there is a focus of necrotizing retinitis with vessels leading to it are sheathed. Fluorescein angiography showed late perivascular staining and hot disk. And at the focus of necrotizing retinitis, we can see hypofluorescence surrounded by staining and occlusive vasculitis leading up to it. OCT showed us a very nice macular scan. Why nice? Because you can predict this is a vasculitis from OCT. It is not a sure sign, but you can find this. Vessels are swollen and surrounded with edema. Disc was showed mild swelling and hyperreflected dots above it showing vitritis. OCT macula was showing mild macular edema, but at the infected focus we can appreciate there was acroiditis, retinitis, and vitritis. So the patient is immune competent with granulomatous chorioretinitis, vasculitis, vitritis. Vasculitis is both arterial and venous, branch, and occlusive. Toxoplasma IgG and IgM were ordered, both were positive, especially IgM. We should rely on the IgM, not the IgG. IgM means a recent infection. IgG is usually positive from any previous exposure, but IgM means recent infection. So the patient was diagnosed as active acquired toxoplasmosis. In case 2, we find that it is a 19-year-old female noticed a flu-like illness with sudden marked drop of visual acuity following it. Patient was a little bit disoriented. There was no past history of systemic disease. This was the picture. If we look closer, we will find that we have a small arteriolar occlusion and cotton wool spots. If we look toward the periphery, we have also occluded veins with hemorrhages. This was noticed on both eyes. So we are facing a patient, young patient, female, with occlusive small vessels, especially the arteries, central one. And this is a remarkable fluorescein angiography. We found arterial occlusion with hypofluorescence and occluded veins with hemorrhages surrounding them. It was a bilateral affection. So this is a case of microangiopathy with severe vascular occlusion. Is this vasculitis? Don't think so. It affects the branches, very important clinical sign to look for, but unfortunately was not present, was because I suspected lupus. I looked at the patient face, looking for malal flush, but keep in mind that malal flush of lupus usually spares the nasolabial folds, so if it is crossing, it is not that of lupus. And the scoid rashes, unfortunately, they were not close. They were not present. I asked her for dermatological manifestations, she denied any manifestation. So a routine basic immunological and inflammatory markers and bleeding tests were ordered. Tests for anti-nuclear antibodies, anti-double strand, and antiphospholipid were ordered also. There was high SR, anti-nuclear, anti-double strand, and antiphospholipid were positive. The patient was diagnosed with active systemic lupus with antiphospholipid syndrome. I should stress here, lupus is a vasculitis, not a vasculitis disease. It causes vascular occlusion by hypercoagulable state, either by itself or in association with antiphospholipid syndrome. And the disease here is a vascular occlusive disease and not pure vasculitis. A case 3, 45-year-old male complaining of left sudden diminution of vision with visualization of black and red floaters. No history of systemic disease. He was very healthy male patient, in fact. This is the picture. We can find that there was left vitreous hemorrhage obscuring the macula, but at the periphery we find this picture. I couldn't say what is this picture. I suspected neovascularization, but a very nice fluorescein angiography showed occlusive vasculitis with secondary new vessels, that together with hemorrhage and retinal ischemia, severe retinal ischemia. According to the history, the patient is immune competent. He didn't complain of any previous diseases with occlusive peripheral branch vasculitis, mainly phlebitis, with secondary retinal ischemia, neovascularization, and vitreous hemorrhage. Differential diagnosis with TB, ELS, and Behçet. Absence of other criteria of Behçet made it unlikely. So tuberculin, intradermal test, and chest CT was ordered. And again, I will stress that it is chest CT. Please don't order chest X-ray. Tons of data are shown by chest CT that are not shown in ordinary X-ray. Highly positive tuberculin intradermal test was detected that was more than 15 millimeter in duration. However, normal chest CT scan was obtained. As usual, extrapulmonary TB. Patient was diagnosed with ocular toxoplasmosis. I should stress here, I don't refer patient for chest hospital directly. They will not obey my orders, okay? I collaborate with a chest doctor, professor, and you should have your multidisciplinary team. We don't have multidisciplinary team in our practice. You should build up your multidisciplinary team. You should have a very good colleague at immunology, chest, neurology, that will make the path of the patient easier. Our patient should not wait for 3 to 4 weeks or months until they have the checkup by other branches. You should have your personal communication with them. The chest doctor referred him and he received anti-tuberculous drugs. In fact, he was very good later on. Case for 16-year-old male experienced recurrent attacks of blurred vision, photophobia, redness in both eyes. He had a grade 1 anterior chamber cells and flare, few posterior synecdoche, and a few vitreous cells. No past history of systemic disease. However, there were recurrent painful mouth ulcers that recurred more than 3 times yearly with no history of genital ulceration. Now he is complaining of right diminution and blurring of vision. As you can see, this is a picture of retinal venous occlusion. Yes, it's a retinal venous occlusion. But from the recurrent painful mouth ulcers, I am suspecting Behçet. And Behçet is occlusive vasculitis, right? No, Behçet starts with this picture. Behçet usually, in the early phases of the disease, we can find the furning sign in fluorescein angiography, which is a massive venous and capillary leakage. This is the first sign of Behçet. So, patient is having anterior and posterior uveitis. There are recurrent painful mouth ulcers, but not genital one. Fern-like fluorescein leakage due to inflammation and the retinal capillaries. is clearly demonstrated in the mid-phase of fluorescein. Reviewing the American Academy, this finding is seen in cases with acute ocular pressure and is an early sign of active inflammation that may be associated with larger vessels and optic disc leakage or staining. It may not be associated with retinitis, and retinitis in patient is very characteristic. It's called chalky white retinitis. Treatment at this stage prevents the exclusive attack with further occlusive vasculitis. So this is the early form that may turn in later on with the occlusive vasculitis form. Although no other clinical manifestation was reported, the patient had skin lesion similar to those shown in the pictures. These are the acneiform eruption of Behçet that we call it pseudofolliculitis. He reported treating them many times and it was resistant to treatment. These are one of the skin manifestation of Behçet. If we didn't take in consideration that the patient is in these stages, we have a patient with recurrent painful mouth ulcers, skin lesion in the form of acneiform rashes, ocular inflammatory disease. So we have a patient with incomplete Behçet disease. Case 5 is not a purely vasculitis, but it is a case to make you happy and show how much the history can make your life easier. This is a male patient coming complaining of marked diminution of vision with anterior uveitis and posterior uveitis. In this, taking this picture, we have focal whitish yellow lesions in both eyes with vitritis, chorioretinitis, and on fluorescein angiography, we can find that there is also vascular staining, diffuse vascular staining along the veins. But from this picture, I have diagnosed the patient because he reported that he has a recent urethral catheter to remove a urethral stone. This is a cause of systemic candidemia. And the typical picture of systemic candida endophthalmitis makes the diagnosis very easy. He was referred to a doctor, vitreoretinal surgeon, with positive test for candida after vitreous aspiration. This is the OCT showing the colonies coming from the choroid and traversing the retina upward until they reach the vitreous. Patient is immune competent, he was diagnosed with candida endophthalmitis. So what makes our life easy are the clinical milestones. Systemic milestones should be known very well. History and history and history can save you many months of investigation and save the patient years of suffering. Thank you.
Thank you very much, Professor.